Okay, let's get started. So welcome everyone to the HNRCA Monday seminar series. Today we have a presentation from our invited speaker, followed by time for questions. We'll be using the Q&A box to submit questions. Feel free to type your questions into the Q&A box at any time during the talk. Our speaker today is Professor Anne-Marie Minihane, Professor of Nutrigenetics at the University of East Anglia in the UK, and Head of the Nutrition and Preventative Medicine at UEA. Professor Minihane's research interests include N3 fatty acids and cardiometabolic health, APOE4 disease associations, cognition and Alzheimer's, and her research is translational, spanning preclinical experiments and human intervention trials. Here at the HNRCA, we have a similar emphasis on translational research, and we are also very interested in the debate on the role of N3 PUFAs in cognitive health. So we're very excited for your talk today. So I'd like to now introduce and give a warm welcome to Professor Anne-Marie Minihane.
Thank you very much, Catherine, and thank you for the invite to speak to you today, folks. Yeah, greetings from the east of England. Now, apologies, my office lights are on sensors and they seem to be plunging me into darkness on a regular basis, so I'll just have to cope with that. So I apologize if it suddenly gets a bit dark in the background. Folks, today this is what I would like to cover over the next 45 minutes or so. Just to give a brief introduction on dementia and cognition, then talk about the impact or the potential impact of altered lifestyle behaviors, with very much a focus on eating behavior and in particular a plant-based Mediterranean style diet, and then narrowing it down to fish and omega-3 fatty acids. We've got very interested in recent years on what happens to cognition during the menopausal transition. And what I hope I'll convince you by the end of my talk is that APOE4 women, particularly as they transition through the menopause, are a high-risk group and would really benefit from being targeted with interventions such as HRT, which we're working on, and also omega-3 fatty acids. So for some of you, this might be old news, but just to introduce the topic to those who are not so familiar, dementia, of course, is an umbrella term which describes a range of symptoms. And those symptoms include things like a decline in memory function, a decline in verbal fluency, a decline in executive function, with executive function being defined as our ability to plan, to multitask, to organize ourselves, to concentrate, attention, inhibitions, those kinds of things. So executive function is our ability to kind of plan tasks and execute tasks. Dementia has a whole host of underlying causes, with about 2/3 of dementia cases having an underpinning of Alzheimer's disease. In the UK, we have about 1 million cases currently, and it's the #1 cause of mortality in women. And it affects about 1 in 14 over 65, very much age-related, affecting 1 in 6 over 80. Looking at some of your US statistics, 1 in 3 seniors in the US die with Alzheimer's disease or another dementia, and it kills more people than breast and prostate cancer combined. And you have about 6 million sufferers currently in the US. Of course, our aging population demographics is a tremendous success story by any standards, but this has huge challenges associated with it, none more so than the impact it has on our number of dementia cases. Because, of course, dementia is very much a disease of older age, and there's a very sharp increase in the number of cases as we go from our 50s into our 80s and 90s. And these are UK data, and you can see the increase in the percentage of people living with dementia as we go through the latter decades in life. And also what I'm starting to highlight in this slide is that there are more female sufferers than male sufferers. In the UK, 65%, about two-thirds of our cases are women. And in the US, actually, similar statistics, about 6 out of 10 dementia cases are women in the US. And I'll come back to that throughout my talk as to why that might be, and highlighting women as a particular target for intervention. Now, the higher dementia case number in women is not just due to the fact that women live longer. Women live about 4 years longer in the UK than men. But when you look at age standardized dementia rates, you can see that they're higher at all ages over about the age of 70 or so. So the higher caseload is not due to the fact that women live longer. What about the trajectory? Well, the trajectory, because we are very much aging populations, especially globally, you can see that the number of cases globally is predicted to increase to about 152 million by 2050. Interestingly, age standardized rates, and actually encouragingly, age standardized rates are stabilizing. And actually for us in the UK, even though we're predicted to have a 75% increase or so, 75% or so increase by 2050, you can see that age standardized rates, if anything, are coming down, which is very encouraging. In the US, age standardized rates continue to increase, even though relatively modestly. But yeah, one would hope that the age standardized rates would start to come down also in the US in the coming years. The reasons why we're seeing age standardized rates coming down in the UK has been attributed mainly actually to our interventions which have targeted cardiovascular health over the last 3 decades, which have been pretty successful at a national level. We always focus on the fact that so many people have dementia, but I always like to turn that around. I'm more of an optimist than a pessimist by nature. In the UK, although 1 in 14, 7% of us over the age of 65 have dementia, of course that means that 93% of us are dementia-free. So I always like to present how can we ensure that we remain in that 93% bubble rather than slip into the 7% bubble over the course of our lifetime. And that's what I'm going to talk about today. Now, the research that we do is not just about reducing our dementia risk. Of course, we all want to retain as much cognitive health as we can into older age. And cognition is defined technically as the mental action or process of acquiring knowledge and understanding through thought, experiences, and the senses. And it includes such domains as attention, memory, problem solving, decision making, planning, inhibition, etc. All of those different brain faculties go under the umbrella term of cognition. If we can preserve cognitive function, even by a small amount into older age, it has a huge impact on the number of cases nationally. So the UK data is a 2 or 5 year delay onset will reduce case numbers by 19% and 33% respectively, just because of that very strong association with age. Similar statistics have been produced in the US. These are rather old statistics now produced by Ron Bruckenmaier and group, that even a 2 year delay in onset could reduce the prevalence by 22% by 2047. Now, what is the likely effect size for lifestyle behaviors and Alzheimer's disease? And this is a very nice analysis which was produced by Martha Claire Morris and her group a few years ago. And it scored folks on the basis of 5 lifestyle factors: smoking status, physical activity, alcohol consumption, high quality diet, which was scored on the MIND scoring system, and whether or not one engaged in late life cognitive activities. And if you scored a 4 to 5 versus 0 to 1, your hazard ratio for Alzheimer's disease was 0.4 over the 6-year follow-up period, which was quite an impressive size effect. But even more encouragingly, I think, increasing your score by 1 reduced your risk by 27%. Just demonstrating in one slide the potential size effects for lifestyle behaviors on risk of dementia later in life. Of course, the focus of what we're talking about today is eating behavior and nutrition, and I will move down the left-hand side of the slide here as I go through my talk. We're doing a lot of work recently on the health benefits or the cognitive benefits of a plant-based Mediterranean-style diet on cognitive health and decline. Also, we're very interested in fish as a component part of the Mediterranean diet, and in particular, the omega-3 fatty acid component of fish. So I'll move down through the left-hand side of my slide as I progress over the next 30 minutes or so. Just to point out an often forgotten factor is dehydration is one of the most common and often forgotten causes of poor cognitive ability in older adults. And it's the simplest way for many to improve cognitive function, but as I say, often forgotten. When we talk about a Mediterranean-style diet, what do we mean? Well, when you take the 21 countries which make up the Mediterranean basin, there obviously is differences in the diet they consume. But typically, a Mediterranean-style diet is rich in whole plant-based foods, things like fruits, vegetables, whole grains, legumes, and nuts and seeds. Olive oil is the main commonly fat, consumed in reasonable amounts. Herbs and spices are used to flavor food as opposed to salt. Fish and seafood are consumed at least two to three times a week or more, with things like red and processed meat and honey and sugar-sweetened confectionaries and other goods consumed irregularly, generally less than once a week. If alcohol were to be consumed, it's usually of the red wine variety, consumed in moderate amounts rather than in great big vats at the weekend, and consumed with a meal. Now, adherence to a Mediterranean diet was the only dietary approach that was highlighted in the Lancet Commission report published in 2017, with a Mediterranean diet purported to reduce brain inflammation, and also in the Circle, which was reporting on approaches which were very, very generically reported as reduced brain damage. What is the evidence? Well, the evidence is nicely summarized in this umbrella review of meta-analysis, which was published in 2018, which included 14 individual publications, 27 meta-analysis, and 70 individual studies. And it looked at a range of outcomes, and I'll focus your attention on the mild cognitive impairment in Alzheimer's disease. And what this meta-analysis summarized is that people who are adherent versus low adherence was associated with a 30 to 40% reduced risk of MCI and Alzheimer's disease, with the effect size, as you will see, greater than for other chronic outcome measures such as type 2 diabetes or cardiovascular endpoints. Now, lots of the research to date has been conducted in Mediterranean countries, increasingly not, but traditionally very much so. So over the last few years, we've embarked on a program of research to look at the benefits of Mediterranean diet adherence in a UK population, and to see if it's associated with equivalent benefits. Because there's a lot of concern that a Mediterranean-style diet, of course, is more than a diet, that it's an entire lifestyle, which you can't mimic outside the Mediterranean basin easily. And also, of course, we are often consuming foods which are locally sourced, which may have different bioactive content to the foods grown in the Mediterranean basin. So, very interesting question. If we adapt a Mediterranean-style diet in our countries, will it be associated with the same benefits? And the first analysis we did was on the EPIC Norfolk cohort, relatively small by prospective cohort standards. We took 8,000 individuals followed them up for 15 years, quite detailed dietary profiling of these folks. And we took 3 measures of Mediterranean diet exposure, including the Mediterranean diet adherence score, which is a 14-point scale. And us folk in the UK, on average, scored 3.3 at baseline. And very encouragingly, yes, indeed, a Mediterranean diet adherence was associated with better cognition, global cognition, verbal episodic memory, and also prospective memory. But we were actually really, really blown away with the size effects. And even a 1-point increase in the Mediterranean diet score on a 14 to 15-point scale was associated, depending on the scoring system you used, with between a half a year to 1.7 fewer years of aging was the equivalent cognitive benefit, which was very encouraging. We have just done a follow-up analysis on the UK Biobank, which was in a larger group of people, over 60,000 folks. And in this time, we weren't looking at cognition, we were actually looking at incident dementia. And we found again that, particularly with the MEDAS continuous scoring system, that higher adherence was associated with a very nice 23% reduction in incident dementia cases. And we've just submitted that for publication. Also, there's been a lot of work published on Mediterranean diet adherence and brain atrophy and neuropathology. And rather consistently, Mediterranean diet adherence has been shown to be associated with higher brain volumes, particularly in the medial temporal lobe, which is an area particularly affected in Alzheimer's disease and dementia. Also with decreased amyloid load using PET. Also with increased or more efficient glucose metabolism, and also with reduced biomarker load, such as an increased CSF beta amyloid 42:40 ratio, reduced phosphorylated tau 181 in the CSF, and also a Mediterranean diet, which I think is really insightful, actually disconnected the neuropathology from actually the brain atrophy. So it actually reduces the effects of neuropathology on loss of brain volume. What about randomized controlled trials? Well, the randomized controlled trials are few and far between, and we've been engaged in 2 of those over the last few years. And the first of those I'll present to you today. The second, the Apple Tree Project, is a large 2-year intervention in over 700 individuals. And that's very much ongoing, but I will present to you today the results of the MEDEX study. The MEDEX was a pilot and feasibility study to see if we can get folks in the UK adherent and if we can deliver an intervention which is effective at increasing people's adherence to a Mediterranean diet. So we recruited 108 individuals in 3 centres, Norwich, Newcastle and Birmingham. We recruited people who had a cardiovascular risk profile defined as a QRIS-2 score greater than 10%, which means people had a 10% chance of having a cardiovascular event in the next 10 years. And we had 3 groups, a control group, a Mediterranean diet intervention group, and a combined Mediterranean diet and physical activity group. The intervention consisted of 4 components. Individuals could define their own dietary goals and physical activity goals. We had 4 group sessions as part of the intervention. We had food delivery to each household once a week, and we also had a digital component to our intervention. And the targets were that we increased people's MEDAS score by 3 on a 14-point scale over 6 months, and that people increased their physical activity to the recommended level in the UK, which is more than 150 minutes of moderate to high intensity per week. And the intervention was rather successful, and we were very pleased indeed. So these are the MEDAS scores in our participants at baseline. You can see they averaged about 6 to 7. And in our Mediterranean diet groups, we managed to increase the scores by 3 to 4 by 6 months of intervention. And I will use the same statistics in all the slides coming up now. The P1 is comparing the 3 groups. The P2 is comparing the 2 Mediterranean diet groups versus the control. And the P3 is comparing the 2 Mediterranean diet groups with each other. In this intervention, the primary outcome was behavior change. We were in no way powered to look at cognitive outcomes, but we included them to see if we could get some sense of a biological signal for our main trial, which we're just about to go on to. But much to our surprise, we actually saw an effects of intervention even after 6 months on global cognition, with the combined group outperforming the other 2 groups. The global cognition score had 3 components. It had a memory component, an executive function, and a processing speed. We didn't see any effects of intervention on processing speed, but encouragingly, we did indeed see an effect of intervention on memory, with again the combined group performing better than the Mediterranean diet group, performing better than the control. And this was particularly reflected on verbal paired in immediate memory. And also in the Ray auditory verbal fluency. Also, we saw an effect on our executive function Z score, and separate to our neurocognitive test battery, we also included the hailing test for executive function. And again, we saw an effective intervention on the hailing performance. And we're now planning to take this to full trial in larger number of people nationally. And we're just in the planning stage for that. We think that a lot of the benefits of a Mediterranean diet and cognitive function are likely to be mediated through improved cardiovascular health. And there's a lot of evidence that cardiovascular health contributes to the progression of dementia by a whole variety of underpinning mechanisms. And we're particularly interested in this from the point of view of when women transition through the menopause. When women transition through the menopause, it's associated with a rapid conduit artery stiffening and an increase in blood pressure. And this very much has knock-on effects for cerebrovascular function, and in particular results in excessive pulsatility in many organs, including the brain. And one of the reasons we think that we see this rapid loss of neurocognitive function as you transition through the menopause is it's very much sort of underpinned by cardiovascular mechanisms, which is an area we're very interested in. Now, moving on to fish and omega-3 fatty acids as a likely very bioactive component of the Mediterranean diet. I don't need to spend too much time on this one. When we say long-chain omega-3 fatty acids, we mean EPA, DPA, and DHA. The recommendation are typically about 0.5 gram of EPA, DHA per day. For primary prevention, increasing to about 1 gram of EPA, DHA per day for secondary prevention. And that's operationalized in many countries, including the UK, by a recommendation to consume 2 portions of fish per week, one of those which should be oily. The brain is particularly enriched in DHA. So when you look at different organs in the body here, and you compare their DHA content, the cerebral cortex is particularly enriched in DHA. And when you look at the brain, the synaptic membranes are again particularly enriched in DHA. Up to 40% of membrane lipids in the synaptic lipids can be constituted by DHA. And this is just data from one of our rodent studies, which I'll come back to later, which looks at different phospholipid fractions, phospholipid ethanolamine, phosphatidylserine, and phosphatidylcholine. And you can see that these particular lipid fractions contain a high DHA content, particularly PE and PS. dementia is associated with a lower omega-3 status, for sure. The brain of dementia patients has, it's not been consistently demonstrated, but there is evidence to suggest that dementia brains have lower DHA levels. Whether that's cause or effect is difficult and remains an unanswered question, really. But this was a relatively old review now, which was published by Stephen Kinane and colleagues in 2013, and it looked at different brain regions and it compared dementia brains to control brains in the hippocampus, the parahippocampus, and different cortical regions. And you can see strong hints of lower brain DHA in dementia brains. And that's been repeated more recently by Hussein Yassin and his group in the University of Southern California. And I won't spend too much time on this in the interest of our overall time, but I'll just refer you, or I'll just divert your attention here to, this is normal cognitive status, and this is Alzheimer's disease, and it looks at APOE3 and APOE4. And you can see, particularly for EPA and DHA, there Hussein and his group demonstrated lower EPA and DHA in the brains of Alzheimer's disease versus those with normal cognitive status. Interestingly, also, he looked at an array of lipidomic markers which are derived from EPA and DHA, and he found, for example, lower neuroprotection D1 and higher concentrations of a whole host of resolvins, resolvin D1, D3, D4. He found that those were consistently higher in the brains of Alzheimer's disease versus those with normal cognitive function. So definitely there's indications, at least in association studies, of altered brain EPA and DHA and their lipidomic derivatives in Alzheimer's disease. Also, there's a whole host of preclinical evidence which demonstrates that DHA benefits all of these sort of metabolic pathways in the brain, and a particular pathway that we've been interested over the years is neuroinflammation. And this is a rather busy slide, but EPA and DHA are the precursors for a whole host of pro-resolving mediators, the E-resolvins, the lipoxins, the muresins, the D-resolvins, and the protectins. And we've been interested in how these change with age and how these are affected by gender and menopausal status. So the prospective cohort evidence is very supportive of a benefit of fish for brain health. And this is just an example of one of those publications, which was an accumulation of data from the French 3-city study, from the Nurses' Health study, from the Women's Health study, and you can see others as well, the Roche Memory and Aging Project. It involved in total over 23,000 white persons, and it looked at the association between fish intake and global cognition and episodic memory over a period of time, with a median follow-up of 4 to 9 years. And it found consumption of greater than 4 servings of fish per week versus less than 1 serving of fish per week was associated with cognitive benefits, which were rather large. They were equivalent to 4 years of chronological aging. And there's been a lot of other prospective cohort evidence. This is probably the biggest study which has been published to date, which is the NIH AARP Diet and Health Study, which followed folks up for 16 years. It involved almost 500,000 participants, recorded 85,000 deaths, and it looked at a quintiles of EPA and DHA intake and all-cause mortality and Alzheimer's disease mortality. And you can see here a rather large effect size for Alzheimer's disease mortality, with an even greater effect size in females rather than compared to males. And you can see here what the levels of intake were in quintile 5. So relatively modest, I would say. And overall, what the prospective cohort data is telling us that consumption of 0.1 to 0.2 grams of DHA per day is associated with improved cognition, reduced Alzheimer's disease risk and death, and higher total and hippocampal volumes, which, as I say, evidence of greater benefits in females. What about the RCT evidence? The RCT evidence, I have to say, is much less convincing and much more mixed. And I'll present to you now two studies of ours. The first is a study I was involved in when I was based in the University of Auckland in New Zealand. And this was a positive study. So we recruited 176 adults between the ages of 18 to 45 who had a very low intake of DHA habitually. And we intervened for 6 months with 1.2 grams of DHA per day. And we saw very nice effects on both episodic memory and working memory. A subsequent study, which we've just submitted for publication, is the CAN study, which was conducted between Illinois, us here in East Anglia, and also Melbourne, Swinburne University in Melbourne. And we were looking at the additive, potentially synergistic effects of DHA with flavontriols from cocoa. This is the protocol paper from that study. It was a 1-year intervention, 240 participants, 120 from each site, and we recruited people with subjective memory impairment or mild cognitive impairment. And we excluded people who had a EPA or DHA omega-3 index greater than 6% at baseline. And the groups were matched for APOE4 status. It was a 1-year intervention with 1.5 grams of DHA and EPA per day, plus 550 milligrams of flavonols. And we took assessments at 3 time points. We saw the expected effects of intervention on DHA and EPA in plasma at 3 and 12 months. You can see we saw a nice 2 to 3 fold increase in plasma EPA and DHA. But rather disappointingly, we saw absolutely no cognitive benefits whatsoever. It couldn't have been more than a flat line if we had tried. This was our primary outcome measure, which is very much a hippocampal sensitive marker of short-term memory, picture recognition task, and we saw absolutely no effect on this particular outcome measure or any of the other cognitive measures. Likewise, we saw absolutely no effect of intervention on medial temporal lobe volumes, and presented here is the hippocampal volume. You can see over the course of 12 months, we saw the expected decline in hippocampal, modest decline in hippocampal volume. And if anything, the decline was more significant, although not statistically significant. If anything, the decline was more significant in our intervention group compared to our control. So this is very much a negative trial. And I've been involved in a working group which was led by Hussein Yassin as part of the Alzheimer's Association. And we've published findings from our discussions over the last year or so. We published them recently in Lancet Healthy Longevity, which looks at the nutrition state of the evidence and dementia prevention, and why there seems to be this type of disconnect between often very positive findings in prospective epidemiology and null findings or very modest size effects in RCTs. And for the field of fish and EPA and DHA, we've come up with sort of a range of things, or I've come up with a range of things which one ought to consider when designing the trials, and that we need to get far smarter when are designing our interventions to make sure that our interventions are fit for purpose. One of the key considerations in my mind is often the interventions are too short, and we have to remember that the half-life for brain DHA is 2 years. And if we're expecting our intervention to have cognitive benefits based on changing the fatty acid profile of brain membranes, then we have to give time for that enrichment to occur. Also, often our cognitive measures are not fit for purpose, and they're often not targeted. We tend to use the same cognitive batteries regardless of what we propose our mechanism of action is for the benefits of our dietary intervention. And we also discussed in this paper how you design interventions differently depending on whether you're doing population interventions or whether you're doing targeted interventions in at-risk subgroups. And for the last 10 minutes or so of my talk, I would like to talk about a particular at-risk subgroup which we've been very interested in recent years, which is APOE4 carriers. So APOE4 is the most important common genetic determinant of Alzheimer's disease risk. If you're E3, the wild-type genotype, the typical age of onset of Alzheimer's disease is 84. If you're an E4 carrier, you have an earlier age of onset, and your odds ratio for Alzheimer's disease is about 4-fold higher. If you're double E4, your age of onset is often 20 years earlier, and your odds ratio is about 16-fold higher. So a major risk factor, and there's a lot of knowledge now as to the underpinning basis for that association. So E4 carriers, even though they only make up 20 to 25% of the general population, they make up anything up to 65% of Alzheimer's disease patients. And for example, if you take North America here, you can see that about 10% of Alzheimer's patients are E4, and about 60% are E3, even though E4 carrier status is only 25% of the general population. If you're E4 and female, E4s and females are only about 12% of the general population, but can make up 40% of the Alzheimer's disease population. So E4 females are very much a high-risk early onset group. And we've been very interested in why that is. And could it be something to do with differences in DHA status or DHA metabolism in the brain? I'll skip that slide in the interest of time. So this is a very simple first study we did, where we just took APOE3 and APOE4 targeted replacement rodents of different ages who were males and females. And we looked at the DHA level in the cortex and the hippocampus. And we can see that as animals age, their brain DHA levels go down. This was particularly so in females, and it was particularly so in APOE4 carriers, more so in the cortex than the hippocampus. And we found that this was particularly evident in the PE fraction, the phospholipid ethanol amyl fraction, even though there was also some evidence of it in the PS fraction, but no evidence of it at all in the PC fraction. We also found that APOE4 status was associated with a dysregulation or differences in the productions of the pro-resolving mediators. And in particular, this one here and these two groups of compounds here, again, they tended to be lower levels of them in the brains of the older E4 versus the older E3 animals. We've then gone on to add to the equation menopause, and what is the effects of menopause on DHA and also on other elements of neurocognitive function according to APOE4 genotype status. And it's not surprising that menopause affects brain function, because if you look at all different areas of the brain, they're very, very enriched in estrogen receptor alpha, estrogen receptor beta. For example, areas such as the hippocampus, the prefrontal cortex, etc., are as I say, very estrogen responsive. We produced a model in our laboratory of menopause, which is far more similar to a human menopause than ovarectomy. Ovarectomy is simply taking out the ovaries. What we do is we administer a chemical called VCD, vinyl dicyclohexene diapoxide, which targets the follicles in the ovary, the primordial and the primary follicles in the ovaries, which produce estrogen. And it induces a gradual menopause in these animals over time. And what we found, we looked at different elements of cognition. We found that menopause, APOE genotype very much affected spatial memory, but this was relatively unaffected by menopause. But interestingly, we found that recognition memory was very much affected by menopause, and specifically in the E4 animals. We looked at brain DHA levels, and we found again that menopause was very much associated with a decline in brain DHA levels. It didn't seem to be worse in the E4 animals, but interestingly, when we looked at some of the receptors involved in DHA uptake into the brain, the levels of those was very much worse in E4 animals. So we think if these animals age further, then these reduced brain DHA induced by menopause would start to be progressively worse in the E4 animals versus the E3. I won't spend any time on this because I'm keeping an eye on my overall time, but we found that E4 and VCD influenced a whole host of pathways involved in synaptic plasticity. The phenotype, both the object recognition and the brain DHA phenotype was very much rescued by supplementing these animals with DHA. Just the final couple of slides. Hussein Yassin and his group have done very, very nice work indeed to show that E4 carrier status is associated with defective DHA uptake into the brain. They haven't looked at this according to menopause or according to gender, but they have looked at it according to APOE genotype status and have consistently shown defective DHA uptake into the brain in E4s. And we also, this is an old bit of data now, but this is a study where we prospectively recruited APOE3 and E3, these are humans, E3, E3 or E3, E4, about 50 per group, supplemented individuals with 3.5 grams of DHA for 8 weeks. And then we looked at EPA and DHA in different plasma pools, free fatty acid, neutral lipids, phospholipids, and total lipids, in folks who had a normal body weight, low BMI, or folks that had a high BMI. And we found that the enrichment of EPA and DHA in different lipid fractions was very much lower in overweight individuals who are E4 carriers. So there does seem to be defective overall DHA metabolism in E4 carriers, particularly if you're female. And this is my last data slide. This is a bit of analysis we're really excited about, actually. So we've asked the question, what about if you intervene with HRT in females as they're transitioning through the menopause? Is it associated with protection against neurocognitive decline? And we are collaborating with Craig Ritchie and his group at the University of Edinburgh on the European Prevention of Alzheimer's Disease cohort, which involves 10 countries around Europe. And what we did was we looked at cognition and brain MRI in females according to HRT use or not. And this has just been accepted for publication last Thursday, and we're very excited about this indeed. What we found was that HRT use is associated with improved memory only in APOE4 carriers. very consistently, it's also associated with larger brain volumes, particularly in the medial temporal lobe, again in E4 carriers only. And interestingly, the earlier you intervene with HRT in the menopausal transition, the larger the effect size on things like hippocampal volume and memory. So this is something we now hope to take on to RCT. So I'll just conclude by saying fish, EPA and DHA are certainly bioactive components of a Mediterranean-style dietary pattern. The preclinical and prospective cohort evidence is very convincing. RCT's evidence is not convincing. And I think we need to really think about our design and make sure our design is fit for purpose. APOE4 females, although only 12% of the population, they're an extremely high-risk group who may particularly benefit from higher EPA and DHA intakes, particularly during the menopausal transition. And we kind of would like to highlight this as a real window of opportunity for intervention to reduce female risk of dementia later in life. And I would just like to finish by thanking the many people who did the work I presented today, all the participants in our studies and our funders over the years. And I would like to thank you for your attention.
All right, thank you, Professor Minihane, for your talk. It was an excellent presentation. So let's move into Q&A. If you have questions, please type them into the Q&A box. So the first question, Larissa Constantino asks, is the therapeutic effect of fish explained only by the content of N3 fatty acid? Are there any other beneficial components in fish?
Yeah, that's an excellent question. And that could be one of the reasons for the apparent disconnect between our prospective cohort evidence and our RCTs, because our RCTs tend to intervene with omega-3 supplements rather than fish. And of course, fish contains such components as B12, selenium, and others, high quality protein, which are also very, very likely to have cognitive benefits. So yeah, a very good point. That fish and oily fish is much more than omega-3 when it comes to cognitive health.
Okay, and I'd like to add a follow-up, thinking about the difference between those two RCTs and why they had different effects. Was it because one was a whole food type intervention and the other was supplementation? What are your thoughts on why they had different effects?
Yeah, I mean, it's a really interesting question. I mean, the study in New Zealand was very much in younger folks. So they were between the ages of 18 to 45. Our CAN study was not in dementia patients, but people did have existing SMI and MCI. So they were on the trajectory. So I think the cognitive benefits are likely to be more evident probably in younger folks where, I mean, the evidence is suggesting that as we age, there may be deficits in our ability to take up EPA and DHA into the brain. So perhaps the age of the participants could have had something to do with our null effects in our SMI and MCI, whereas the New Zealand study was very much in younger participants, younger, healthier participants. But yeah, we were very, very surprised by the completely null findings in the CAN study because we precluded participation from anybody with a high status to begin with, because I think one of the reasons why RCTs have failed in the past is because we haven't excluded people with a relatively high status at baseline. But in CAN, we were very careful that we excluded people with a high omega-3 status at baseline. Also, we ensured that high flavonoid consumers were precluded from participating. So yeah, and we thought we had quite sensitive cognitive tests. It was a 1-year intervention, well powered. So yeah, we are slightly stumped as to why we saw a completely null effect. Mind you, the results of the Cosmos study, which was a flavonol intervention, have come out relatively recently, and they also have reported no effects of flavonols on cognition over a relatively long intervention period. We can't think of any reasons why the supplementing with omega-3 and flavonols should be a problematic combination. You know, in our mind, it should have been very much additive and synergistic, but that didn't prove to be the case, unfortunately.
Okay. And one more related question. How did the increased diet score this is the first study, compare to what you expected from the intervention diet? You showed an increased score.
Yeah, so this was in the MEDEX study. Yeah, so the MEDEX study, yeah. So we were hoping for an increase in 3 points on a 14-point scale, and we actually did see 3 to 4. And you would expect that, which we did see, that those kind of benefits on a Mediterranean diet score would result in cognitive benefits. We didn't quite expect them within 6 months. But even over 6 months, we were getting a hint of cognitive benefits for sure.
Okay, great. So our next question is from Kelly Cara. Research on cognitive reserve suggests protective effects against AD for people who've experienced greater cognitive challenges over time. Have you seen a difference in AD rates among postmenopausal women with complex jobs, careers, or higher educational degrees?
Yeah, I mean, that's an excellent question, and I think it's a bit of an unanswered question. I mean, I know one of the reasons that's been purported for the improved age-corrected incidence in the UK, particularly in women, is that women are now more educated than they were 40 or 50 years ago. But actually the sort of the combination of menopause and professional status and that kind of very complex relationship is an important one, but very much understudied.
Great. Larry Parnell asks, is EPIC Norfolk study a part of UK Biobank cohort?
Oh, hi, Larry. We've worked together a little bit in the past. It's not actually, they're completely separate studies. They're completely separate studies. So the EPIC Norfolk hasn't been combined into UK Biobank. I mean, one of the criticisms of UK Biobank is marvelous. It's 500,000 people. It's an absolutely fantastic resource. It doesn't have the socioeconomic diversity or the ethnic diversity that was hoped for when it was originally set up. That is the kind of the one limitation, I think, with UK Biobank.
Okay, Larry has a second question. In the med diet intervention study, what is the lipid profile after intervention?
Yeah, we haven't looked at that, and we won't be able to actually, because we were hit by lockdown. So we had wonderful plans for taking blood samples from all our participants, but suddenly we had COVID-19 restrictions, and we suddenly had to deliver our intervention remotely, and we couldn't have folks into the clinical unit to take blood samples. So we actually did manage dry blood spots from some of the participants, which we are hoping to maybe extract a fatty acid profile from, but it's not going to be as easy as we had hoped. But absolutely, it would be a very nice thing to do to actually look at the omega-3 index in red blood cells before and after intervention in our participants. It's just a matter if we can extract that information from the dry blood spots or not.
Okay, our next question, Jennifer Lee says, excellent presentation, thank you. Is there any evidence for HRT benefit to protect against neurocognitive dysfunction in non-APOE4, that is wild type mice or women?
Yeah, I mean, the evidence is so mixed at the moment. You know, as you're probably all aware, the earliest indications for HRT and cognition were very poor. They were from the Women's Health Initiative Memory Study, which was published over 20 years ago now. And what they showed, if anything, was that in women over 65, that HRT had a negative effect on cognition. And since then, the evidence has been really, really mixed and confusing, and it's a very, very kind of mixed field. Nobody's really looked at it according to APOE genotype status. We are kind of one of the first, even though there is another analysis which came out last year in the UK Biobank. And they did show as well, they had a very funny measure of brain aging, which is a bit hard to interpret. But what they found consistent with ours, that for this brain aging measure, that HRT use seemed to be more evident in E4s and was not really evident in E3s. But apart from those two studies, I don't think it's been looked at in any detail at all. So the early indications are that it seems to be more so in E4s, but I think there's a whole lot of research that needs to be done before we can conclude that with any certainty.
Okay. The next question from Marcus Lear. He says, macular degeneration is also associated with fish intake, and the macula is incredibly rich in DHA. That APOE4 individuals are at reduced risk for macular degeneration. What could account for these different disease risks? And could APOE4 be telling us about other nutrient-gene interactions?
You know, I wasn't aware that E4 carriers were reduced risk of macular degeneration. So I won't even hazard a guess as to why that might be. But what it will make me do is go away and read the papers. So thank you very much for the question, because those kind of sort of seemingly contradictions can be hugely insightful. So thank you for the question. I shall get busy in reading.
Okay, here's another question from Kelly Cara, related to Larissa's question. That was the first one. Has your group looked into the effects of plant versus animal sources of EPA and DHA? For instance, could consumption of walnuts, chia, flax seeds be equally protective against AD in populations where fish consumption is low?
Yeah, that's a good question. Because yeah, for vegans and vegetarians who don't eat fish, of course, your plant sources are going to be your exclusive sources, unless you get vegan sources of capsules. The evidence isn't as strong. The prospective cohort evidence isn't as strong, I think, for the shorter chain omega-3 fatty acids. And in prospective cohort studies, it's often difficult to disentangle the effects of omega-3 from an overall plant-based diet. And the intervention studies haven't been done at all. So as far as I'm aware, there's very little intervention work which has looked at alpha-linolenic acid and its effect on cognitive function, which would be the plant sources of omega-3. So, okay. Yeah.
Yeah, all right. I think we have time for one more question, maybe two, we'll see. This might be the last question. So Shangdong Wang asked, I think this is a clarification question. I missed what you said. Are brain DHA, EPA concentrations or uptake differentially affected by sex according to APOE genotype?
That's right. I mean, what we're starting to see is that if you're E4 in females, that you at least have lower brain DHA, and there seems to be indications that there's lower uptake. It could be more turnover. So there's lower status. I think what we've yet to establish is what is the real cause of that lower status. Is it really due to defective uptake into the brain? And the early indications are that there is defective uptake into the brain if you're E4 and female compared to being male or female and non-E4.
Okay, so we do need to end on time today, so we're going to conclude the seminar. Professor Minihane, thank you for your time visiting with us today. Thank you for everyone attending. So there's no seminar next week. I hope everyone has a great Thanksgiving holiday, and we'll see you all in 2 weeks. Thank you. Bye.
Bye-bye, everyone.